good. First of all, I want to again thank to Yannis Yokovu for his kind invitation to this important meeting. I want to show you a very interesting case. It's a 57 years old man. Aortic valve replacement and mitral valve replacement was done in 2010, and reoperation due to severe paravalvular leak and mitral regurgitation, and referred to our Center for Paravalvular Closure. Here you can see severe paravalvular leak, an abscess cave at lateral region of at the level of left atrial appendage. You can see here, I think it's an endocarditis sequelae. So, but the patient had no fever, and the infections parameters were totally normal, CRP normal, white blood cell count and normal, and blood culture was negative. And our heart team decided to close this abscess cave and the paravalvular leak with transcatheter approach. But before the closure procedure, we really look at the abscess cave here, as you see, and measure the distance as the longitudinal distance as 15 millimeter. And please look at the entrance and exit point of the leak, as you see. The atrial entrance point is a little bit wide at 6 millimeter, and the ventricular exit point is the 5 millimeter. And here you can see the zoom, 3D zoom image and the measurement of the leaks, and the atrial and the ventricular part of the entrance and exit point of the abscess cave here. And you know that it's not very easy to image the ventricular part of the mitral valve also. So we made a posterior puncture and put an aguilis sheet, but we tried to cross the leak with the antegrade approach, but every time, as you see here, we were very unsuccessful because the wire always we cross the leak, the wire always move into the abscess cave, and then could not cross the exit point of the leak. So we use our retrograde approach again and successfully cross the leak and snare the pneumoguide wire here, and then create an arteriovenous wire loop. And we use delivery hook flexor sheet inside over the arteriovenous wire loop. And as you remember, we measured the longitudinal distance as 15 millimeter, and we selected the AVP3 12 millimeter device. You know that the discs will be 16 millimeters. But in the first attempt, as you see, the device was not properly settled into the abscess cave.
Thomas, can I ask you a question here?
Yes.
The wire goes through the metallic aortic valve?
Yes.
Does it? Is this a problem?
We always, as you remember from my first speech, we use this approach, but we never, for example, insert the delivery sheets from the mechanical aortic valve, but we cross the mechanical aortic valve with the pneumoguide wire and look at the hemodynamic parameters very carefully. I always check the blood pressure and wait a little bit, but in this case, there is no way to cross and close the leak with the fully percutaneous approach. But the hemodynamic was very stable in this patient.
Okay, thank you.
And the first attempt device was not properly settled, as you see. So we didn't release the device because, as you see, the proximal disc was not properly settled into the inside the abscess cave. Then in the second attempt, device was properly settled, as you see. We also checked this with the 3D, and the device really settled very properly, and we released the device. So the mitral paravalvular leak was completely resolved and no residual leak was observed. The patient's heart failure status was recovered and no hemolysis was observed after the procedure. So this case indicates that catheter-based closure of an abscess cave and paravalvular leak may be feasible and safe alternative to surgical repair, particularly in patients with prohibitive risk for radiosurgery. But in complex cases, measurement of entrance and exit points and major axis of the cave may help in better planning and guiding for the device selection and for the interventional procedure. And the creation of an arteriovenous valve facilitate the insertion of appropriate delivery systems and safe implantation of the device. Thank you very much for your attention.
Thank you very much. That was fantastic. I'm interested in this question I asked before. I don't know if, Yannis, do you ever use this Terumo wire through the metallic valve? Is there any issue with that? I mean, we have crossed a few times, but to do a loop, is this okay? No loop. So this loop through the metallic valve, how does it work? Because you use the loop to pull something, so you would just make the valve fully open. How do you do that?
Mm-hmm. First, during fluoroscopy, we look at the opening of the two discs of the metallic valve, and then we only use the wire, not with any catheter inside the wire. And the Terumo guide wire can easily cross, but sometimes if you, for example, cross not in an appropriate region, the blood pressure can fall down and the hemodynamic problems can be observed. So it's a technique. We also published this technique by looking at the very careful hemodynamic observation.
Is there any comment from the audience, or is somebody who would like to say something? No.
Dr. Vagianakis says you are in the panel. Do you like to have a final comment?
Just want to ask a question. A very nice talk, Dr. Kilic. If the indication for closure of your paravalvular leak is hemolysis, and after closure, your patient still has hemolysis, how do you manage this patient?
Good question.
Well, this is a very important question, and it's a very hard topic. We always discuss this. But the main hemolytic findings are observed really in the early period. And then we carefully observe these patients. And then the hemolytic status will resolve. But if you don't close, for example, the leak appropriately, and I mean, some small leakage and residual leaks, it's another indication for another procedure. So these patients can, for example, underwent one or two procedures. And after putting, for example, the large occlusive devices, there can be some shower effect that we call as some hemolytic problems we observed in the early period, but in 1 or 2 weeks it resolved. But if the residual leak is the problem, we had to take the patient in the cath lab again and close the leak maybe with another device.
Excellent. Thank you very much. Thank you.
Thank you, Apostolos. See you.